Very good morning, everyone. It's my proud privilege to be here to share my knowledge on diabetes in young, a diagnostic dilemma. It is, in fact, a diagnostic dilemma uh, because it is apparently assumed that children who are between 10 and 20 or 18, they are type 1. Generally, it is assumed like that, although it is not true. So I'll be showing you it's a case-based discussion, and that would be really very interesting and clinically very useful. So diabetes in young is going on, it's increasing. Even type 2 in young children is increasing. So overall challenges are very, very important. One is diagnosis itself. So the first lesson which I want to convey is don't be in a hurry to put a label on any type 1, 2 or anything till we have a clear cut picture. Now the second is the problem in these children are cooperation and compliance. They don't listen to anyone. So the parents have to be taken into confidence and a lot of counseling is required for treatment than adults. And the third is, it has been seen, there's a study from All India Institute of Medical Sciences, that the complications are more serious in children, if type 2 is there, than adults. It's not that they live longer, that is one, but even otherwise. Why? Because the onset is in early stage of the disease. So severity of the illness is, so mortality and morbidity will be very high. So we have to be very, very clear in managing these patients and especially the diagnosis. So the first case is a 15-year-old boy having recurrent boils for 2 months, polydipsia, polyuria, polyphasia, 1 week, fever, coming to emergency, weight loss 4 kg in last 2 months, fasting, postprandial both are very high, A1C very high, urine ketones present. Father, is having diabetes. So, weight is okay, BMI is 25, no signs of insulin resistance, C-peptide 0.2 on a lower side, anti-GAD 10, which is normal, is 8. So patient was managed on antibiotics, insulin infusion. Now this patient, this child appears typically type 1. Ketones present, high A1C, polydipsia, urine infection, 10 years of age. Now, so after 10 days, when this child was called and C-peptide was done again, C-peptide has gone up to 0.6. Now, at this point, insulin dose was reduced and child was started on metformin. And he, responded well to metformin. So this is a typically, a case of flatbush diabetes, which is basically type 2 and very high sugars. They are ketosis prone. Not type 2 are not ketosis prone. But this is a special, flatbush ketosis prone diabetes. So glucose levels are very high, ketones are present, and because of that, there's an insulin deficiency severe. And because of glucotoxicity, C-peptide also goes down, and it appears like, it is type 1, and ketones also positive. So what I want to say that don't label this, because once you label type 1, take my words, nobody will change it. So treat the patient, follow up the patient, and C-peptide will gradually rise if it is type 2. Even the insulin levels will. So in acute glucotoxicity, the levels and antibodies, even in normal population, around 10% of type 2 diabetic patients also have antibodies plus, but the levels are low. In this, it is 10. Normal is less than 8. So it's a borderline. So don't confuse. Even if antibodies are present, don't take it as, don't label. This is the point. So take your time, 2 to 3 weeks time, and then label the patient. So this was, basically a lesson to learn from this. Now, this is, so basically, what we have to see is like in autoantibodies and beta cell function. Now, if antibodies are there, beta cell function is not there, it is generally autoimmune. When both are not there, we know it is idiopathic type 1, which is B. Antibodies plus beta cell. LADA again, from 25 to say 35 years of age, BMI is normal and they have antibodies, but beta cells are also. Because you put them on OADs, they respond to OADs initially for 6 months. After 6 months, they stop responding. So basically, they are type 1, but for small period of time may respond to OADs. So that point has also to be understood that this is not type 2. Because adults are taken as type 2. I mean, that's what is generally, at least as healthcare physician level, it is like that. So a lot of patients who are LADA are labeled as type 2 and on OADs, and levels keep on rising. We never give a second thought. Now, this is another case, 18-year-old girl having type 1 diabetes for last 10 years on basal bolus regime, well controlled 7.2, now coming to us with UTI for 2 months on antibiotics. Glucose levels are very high, A1C 8.5, BMI 26, skin tags plus, blood pressure 130/84, even a bit rise in lipid levels. Okay, so this is a typically type 1 diabetes, well controlled, but now going on to type 2, there is something known as double diabetes. Because of the availability and longer lifespan of type 1 now, they consume the same diet as adults and they develop features of insulin resistance. Okay, so what I want to, this is another a small lesson. Even typical type 1 patients on insulin, but if they have dyslipidemia, a little high, they need metformin. They need now something more than insulin, other way around now. Okay, so this is another example. So that it's a double diabetes mentioned in the literature, type 1 going on to type 2, and they need now some addition of, even they may need antihypertensives or lipid lowering agents. Okay? Now, this is a typical, case 3, a 15-year-old girl having symptoms, classical symptoms, having diabetes for last almost, 13 years on basal bolus. Now, these cases are also there. We say in India, this is type of diabetes is not seen because we are not thinking what our mind doesn't know. Our eyes won't see and we won't be doing the test. So patient is on insulin, A1C 9.2, mother is having diabetes, ketones negative, patient is lean and thin, no features of insulin resistance. So this is a typically we should here think of MODI. Try to understand. No features of insulin resistance, no ketone. Patient is already on insulin. We don't know, we don't diagnose, and we see that MODI is not there in India. Try to understand. So this patient, now mother is having diabetes. So for MODI, it's a 3-generational, transmission. So here's the catch. Mother is having diabetes. So try to find, patient's sisters, maternal grandmother, whether they are diabetic or not. Just, clinically only we can find out. And then we can do genetic testing later on. Okay? So C-peptide normal, classical. So patient does not have any C-peptide, deficiency, lowering of this thing. So it's a typical, only a thought process. Such cases are neither type 1 or 2. And they are something different. Patients already on insulin because MODI is, responds very well to sulfonylureas, small dose of sulfonylureas. So unnecessarily, what I want to say, patients are on insulin, they need OAD, and vice versa. Sometimes, LADA you keep on giving, thinking it's type 2 OADs. Okay. So when pedigree charting was done in this child, so this is the patient. Okay. This is the patient, sorry. Her sister was also found to be having diabetes. Okay? Mother is diabetic, and we can see here, even the maternal, the sisters of mother, you can see. See, maternal aunts, they're also diabetic. So only by pedigree charting and doing the test, we can find out. But first we have to suspect. suspicion of diagnosis is very important. Because patient is on insulin, not getting controlled, why unnecessarily we continue? So there are so many patients like that, you will now understand. And they keep on, they change one doctor to other doctor, but fail everywhere. So this patient was put on very small dose of glimepiride and patient responded well. So this is another case where it was thought as type 1 and it is MODY. Okay? So we should, think little out of the box. Don't label. This is the first thing. Take your time and a good clinical, which is now going, when now AI is coming, I don't know how much even the rest, we are dependent only on digital technology. Clinical history is very, very important and we take a proper history. I think 70–80% of the diagnosis can be made on history taking. So this is basically, a monogenic type of diabetes, MODY, and one is neonatal. Neonatal again responds very well to sulfonylureas. Okay, now. So these are different types of MODY. Type 3 is more common, and in India also 3 is more common. But for that, we have to do genetic testing. And diagnostic criteria, generally, age less than 25. It's an autosomal dominant, 3-generational, transmission, absence of ketosis, normal C-peptide, no insulin deficiency, and can be managed without insulin with sulfonylurea. But yes, clinical criteria not valid. Like you have to get genetic testing to prove. But at least clinically, you should make, a provisional diagnosis. So, these people, they don't need insulin. And so MODY 3 is basically, defect in glucokinase gene. And MODY 2 is very, very mild, doesn't even need treatment. Now, this is my, the last case, again, a small, 23-year-old male and having diabetes for 2 years, having a history of pain abdomen, which is normally, there people take it as acidity problem or something in general. And passing oily stools on off and on, no family history of diabetes, non-smoker, non-alcohol, no alcohol intake, patient is on OADs. In general, that's what, more than 20 years, any diabetes put on OADs. So, but A1C is high, anti-GAT antibodies negative. So it's not type 1, okay? It doesn't appear to be even type 2. Now, in this patient, if we go further down, there is, grade 1 fatty liver, urine ketones negative, BMI is normal, okay? So there is, one type of diabetes, FCPD, fibrocalculous pancreatic disease, which is more in south part of India, southern part of India, and we can see these small calculi here. Can you see these? On both the sides of T1, okay? So just any patient having some pain abdomen, don't neglect that. It is important. You can get a stool examination done. Can find oil in, fat globules in the examination. And ultrasound will tell us clearly, or even X-ray will be sufficient. In remote areas where ultrasound is not available, X-ray is sufficient. So the only thing is for FCPD, calorie deficiency, low calorie intake is not required, and it is both deficiency of endocrine part as well as exocrine part. So you have to replace enzyme also. Pancreatic enzymes are also to be replaced along with, so they need insulin. They are ketosis, they are not prone to ketosis. So ketosis resistant, lean and thin. So this is another type which I think we should keep in mind. Fibrocalculous pancreatic disease. Again, it's like steatoria and more common in southern part, Chennai and Kerala. And the thing is, if we neglect these, there is very high chances of pancreatic CA. These people later on, they develop this. So overall, diabetes young can be, see, so many. Type 1, type 2, MODY, FCPD, LADA. Then there's another one, malnutrition modulated diabetes, even GDM, because early stages you won't be knowing in a child whether pregnancy, you have to get the test done and the child may not tell. Okay, so GDM, then endocrine disorders also, certain endocrine disorders like acromegaly, Cushing's, pheochromocytoma, certain genetic disorders can also be there, and neonatal mitochondrial defect. This also responds very well to sulfonylureas, glibenclamide, very small dose. Very, very interesting. So we have to keep these in mind. Don't label, wait, take a good history, take history in the family, and do other tests, and then only you make the diagnosis. So this is a flow diagram. Actually, I generally don't believe in, because they appear very confusing. So 4 things are important to differentiate. One is the history. If there's a family history positive, it's either type 2 or it is MODY. Generally in others, the family history is not positive. Clinical examination, signs of insulin resistance. If there, again going in favor of type 2. Then examination on urine. If ketones are there, it's more for type 1. And then autoantibodies and C-peptide. 2 tests are very important. C-peptide is very important test, and I think it should be very oftenly done. That will tell us if it is very, very low, negligibly, then it goes in favor of type 1. And if it is normal, it is not at least type 1. And then obviously autoantibodies. That's how we know. So 4 or 5 things are important. So history, examination, and some test will tell us. So overall, diabetes in young is a big challenge. It's quite common, and all need not be type 1 as we assume. And there's always a diagnostic dilemma, so don't make a diagnosis. Classify after 1 to 3 weeks of follow-up. It may be type 2, MODY, FCPD, LADA. So proper clinical history, examination, few tests, pedigree, charting. Yeah, the most important is it's a big challenge. They don't consider these children themselves as to be the patient. So they don't, the compliance is very poor. So their, relatives, parents, brothers, sisters, colleagues, teachers have to be taken into confidence, because these are the children, they will have more serious complications, as I told you, especially CKD. That will reduce their, the lifespan, as well as morbidity will increase. So this is, so, both ways, it's really very important. So awareness, education, intensive counseling goes a long way to, manage these people. So with this, I conclude my talk, and I convey my thanks to all of you.